for inviting me. And I tried to focus on research in the last year that has the potential to be practice-changing and the new drugs that have been approved for the myeloid malignancies. Although, as you saw in Roland's talk, even if they were approved for AML, they aren't necessarily practice-changing yet. So the first question, and a lot of this is from ASH in 2018. The Medalist trial was a phase 3 randomized double-blind placebo-controlled study of luspatercept to treat anemia in low and intermediate risk MDS who require red blood cell transfusions, and it's a first-in-class drug. And this is just a question about its mechanism. A, it incorporates into DNA and promotes DNA methyltransferase. B, it's a glycoprotein that stimulates erythroid progenitor cells in the marrow. C, it's an inhibitor of the hedgehog signaling pathway. D, it's a spliceosome inhibitor. And E, it's a transforming growth factor beta inhibitor. All right, so it's actually E. Sorry. Sorry. That's the, all right, this slide isn't showing up. That is on here. Okay. It's weird. It shows up on here, but, well, basically an explanation for the structure of luspatercept, as you saw in Damiana's lecture. It actually acts in late-stage erythropoiesis rather than early-stage erythropoiesis like EPO does, and it blocks the transforming growth factor superfamily inhibitors, reducing SMAD signaling, and it's, that's weird. Okay, so in the trial, so yes, it's showing up here.
No,
Yeah.
that's not the way. You need to look at that one.
Yeah, no, it's just, okay. And so, as you can see, it's a ligand trapped at the end of erythropoiesis. And a related drug, sotatercept, is also being studied in the MPNs. So which MDS population has the highest likelihood of response to luspatercept? MDS with ringed sideroblasts and a DMT3A mutation, MDS with ringed sideroblasts and an SF3B1 mutation, MDS with fibrosis and a B-core mutation, or MDS with excess blasts. And it's actually, it was B, MDS with ringed sideroblasts and an SF3B1 mutation. So the phase 2 PACE MDS study, which preceded the Medalist trial, evaluated the drugs first in 60 patients with low-risk MDS, and the predictors of response to luspatercept were a lower baseline serum EPO level, although patients who had an EPO level of 2 to 500 or over 500 still did have response rates of 43 to 58%. 70% of patients with ringed sideroblasts had hematologic improvement in the erythroid line compared to 43% without it. And then 77% of patients with the SF3B mutation achieved erythroid response compared to 40% without. Prior exposure to erythropoietin or lenalidomide did not affect response rate. And however, there were small numbers in this phase 2. This shaped the inclusion criteria for the large phase 3 trial, which required both ringed sideroblasts and the SF3B mutation. And this is in vitro. It makes sense. Patients with ringed sideroblasts in this genotype have alterations in erythroid maturation. And so now there is a head-to-head trial of EPO versus luspatercept in early phase MDS. So based on the results of the Telesto trial evaluating the benefit of iron chelation in MDS patients, which found improved event-free survival in patients receiving iron chelation with deferocerox compared to placebo, in which population should we chelate our MDS patients? Not indicated in any MDS subgroup. Low or intermediate risk patients with ferritins over 2,000, lower intermediate risk patients with a ferritin over 1,000, high-risk MDS patients with a ferritin over 2,000 or 1,000, or all MDS patients who have received over 10 units of packed red blood cells. So the answer is C, low intermediate risk MDS patients with a ferritin of over 1,000. The Telesto trial was a large, randomized, double-blind phase 3 trial comparing iron chelation versus placebo in 225 adults with low or intermediate risk MDS, at least 15 units of blood, and a ferritin of over 1,000, and they were not allowed to have cardiac or liver or renal abnormalities at baseline. The primary endpoint was event-free survival. The iron chelation group was 1,400 days compared to about 1,000 days in the placebo group, and also had a higher 3-year event-free survival. Median overall survival was not different, but some patients on the placebo arm did end up getting iron chelation therapy after coming off trial, which they attributed to the no change in survival difference. And the events they used for EFS was worsening cardiac function, hospitalization for CHF, liver function impairment, progression to AML, which was all higher in the placebo arm. And as I said, death was similar in both arms. Side effects were overall minimal and were similar in both arms when controlling for exposure. And so this has been somewhat practice changing in our approach to iron chelation in MDS. So this is kind of a really small drug and a small study that was presented at ASH in 2018, but has been exciting because of the challenge of developing the drug for this particular target. So this is a drug APR-246. It's being evaluated to reactivate a commonly mutated gene in MDS and AML. It's historically been a challenging drug to target, and which pathway does it control? Epigenetic regulation, tumor suppression, normal early hematopoiesis, the RAS pathway, or RNA splicing? Sorry, it was a hard one. This is also applicable to solid tumors. It targets tumor suppression and basically the TP53 mutation. So this is TP53 mutant MDS is about 5 to 10% of de novo MDS, or closer to a third of therapy-related MDS. It represents a distinct molecular cohort with very poor outcomes. And this is a first-in-class molecule that selectively induced apoptosis in mutant TP53 cancer cells through p53 protein reactivation, and restores wild-type conformation. This was a very small phase 1 B2 trial presented at ASH, only 12 patients when they combined it with azacitidine and TP53 mutated MDS and AML. However, the overall response rate was 100%. When you get that, people start to get a little excited. There were 9 CRs, 82%, and 2 marrow CRs, and then 1 patient was not evaluable. The median time to first response was 70 days, so it took some time. And then they tracked p53 positivity by IHC, which normalized on serial assessment, and serial NGS testing at the level of a 5% allele frequency was negative in 73% of the responders. Median follow-up of 7 months, the median overall survival had not been reached. And the AEs generally were described as causing people to feel drunk, basically, a little bit unsteady, neuropathy, dizziness. So kind of interesting. This is just some of the survival data, and this, the one below the curve is looking at comparing to a historical cohort of azacitidine alone in red compared to the APR-246 with azacitidine, and obviously very short follow-up, but survival was not reached compared to 7.6 months. So this is being rapidly advanced currently both in the upfront setting for TP53 mutated MDS and AML, as well as in the post-transplant setting for the prevention of post-transplant relapse. So as you heard from Roland, recently the FDA has approved Glastigib for patients with newly diagnosed AML after a randomized phase 2 trial comparing LDAC to LDAC plus Glastigib. And what is the mechanism of action combined with a notable side effect? Is it a FLT3 inhibitor that causes prolongation of QT, an IDH2 inhibitor that leads to differentiation syndrome, a CD33 monoclonal antibody leading to pyrexia, a hedgehog inhibitor that can cause muscle spasms, or a CD33, 133 BiTE antibody that can lead to cytokine release syndrome. So it is a hedgehog inhibitor. Muscle spasms are a somewhat unique side effect. It is an oral inhibitor of the hedgehog pathway. And this signaling pathway is involved in the maintenance of neural and skin stem cells and embryogenesis. And the aberrant activation of the hedgehog pathway is implicated in the pathogenesis of multiple malignancies. It's thought to contribute to the development of cancer stem cells and resistance to chemotherapy. And so the trial that Roland mentioned was the BRIGHT trial. It's a multi-center but a randomized phase 2 of 132 patients with newly diagnosed AML or high-risk MDS, and randomized 2-to-1 to receive Glastigib plus LDAC versus LDAC alone. The median survival was somewhat longer in the Glastigib group, 8.3 versus 4.3 months. And they did report muscle pain and spasms, which can be treated with calcium channel blockers. However, as Roland noted, LDAC is not a commonly used single agent in this situation. We don't know its value in combination with azacitidine or decitabine, so I think we are still trying to figure out the value of this drug and how we're going to use it. And the last question, which of the following is true of the trial that led to the approval of venetoclax for AML? It was a non-randomized phase 1b/2 study. The eligibility was age over 65 or ineligible for standard induction chemotherapy. Equivalent outcomes were seen with the combination of venetoclax with azacitidine or decitabine. The CR/CR rate was about 67%, or all of the above. Okay. All right. I had to throw in a slightly easier one. It was, it was all of the above for this trial. So as you have heard already, and you might hear again in a lot of the rest of the talks, this is a BCL2 inhibitor. This overexpression is implicated in the survival of AML cells and the development of treatment resistance. So this was a non-randomized phase 1b/2 study of 145 patients. This is the one that combines it with azacitidine or decitabine by DiNardo. They had to be ineligible for induction chemotherapy, which they defined as age over 75 or cardiac disease, prior anthracycline use, secondary AML, or high probability of treatment-related mortality. So that was very vague. They had to also have a performance status of 0 to 2, an adequate baseline organ function, which is somewhat contradictory to the presence of various comorbidities. And yet the CR/CRi rate was 67%. As you saw in Roland's table, there was activity across cytogenetic, molecular, and disease spectrum, including secondary AML, and cytopenias were the biggest side effect. There seemed to be no difference in combining it with decitabine versus azacitidine or at the 400 milligram or the 800 milligram dose. So it is being used largely now at the 400 milligram dose. It is also approved in conjunction with LDAC based on a separate trial. However, even though the inclusion criteria were medically unfit adults, over 2/3 of the patients had a performance status of 0 to 1 in the actual trial. So it is notable that the trial was not really focused on unfit adults. So I think the question here is how does this perform in the more unfit population, which is a challenge.